All right, well, welcome everyone. And this is our third enrichment training from our Uganda walkthrough. And we are really fortunate today to have Dr. Roger Peters and Dr. Donald. I'm not going to try to pronounce your last name because I'm terrible at that. And I think all of you know me, Carrie Hopkins-Isles. I'm the Deputy Director for ICU DDR. And so because we have new facilitators today, I'm just going to give a little breakdown and I think most of you have been with us in other sessions as far as participants, but basically I have given our facilitators, our instructors, some guidance on some of the things I saw on the post tests that maybe were challenging for participants in these courses 5 and 6. And of course, in addition to us going over some things that you may have struggled with on the post test, we can go over anything that you raise during the conversation. So that being said, I want to start with course 5, which is your intake, screening, assessment, treatment planning, and documentation for addiction professionals. And I want to introduce my colleague and friend, Dr. Roger Peters from the University of South Florida, as well as the UTC Coordinating Center. And I've given him some guidance on some things we might want to discuss, but I'm sure he'll also open it up to questions. So, Roger?
So can everybody hear me? Okay, good.
Yeah.
Welcome. And it's good to be here today. Congratulations to all of you for going through the UTC training courses. I hope you've had a good experience so far. And it's nice to have a chance to actually discuss some of the key topics afterwards that you have questions about. So Carrie has provided me a set of questions and issues that may be important to you based on the post-test, I think, and issues that came up during the training. So I'll go through those and I will stop to see if there are questions, comments, things that you'd like to learn more about in each of the areas. And there may be other areas that aren't even listed here that you'd like to talk about. So I've had a chance to work for quite a few years in screening and assessment in different areas. My focus is on the criminal justice system, but I've worked in other areas as well. And one of the first questions that you had from course number 5 is, when should assessment be carried out? And so I want to start with that. And we know from course number 5 and from your own experience that assessment is a fairly time-consuming process that requires a trained clinician who has expertise in substance abuse and particularly substance abuse treatment, right? In most cases, if you're working in a treatment center. And so we don't want to provide an assessment for everyone who you might see who is being screened for treatment. Once people are enrolled in a treatment program, whether it's an inpatient or an outpatient program, residential or outpatient program, then yes, everybody really does need an assessment to determine their individualized set of needs and what services you should provide in the program, right? And it could be family services, education, it could be intensive group treatment, and so forth. So before somebody gets into the program, though, you're familiar with some of the screening techniques. And I think you had familiarity with the ASSIST instrument that was developed by the World Health Organization and the United Nations, and has been used really around the world. And so that is a good example of a screening instrument that would be administered before somebody gets into treatment. And really it's a way to determine if somebody has a severe substance use disorder, right? So I think the first easy answer, when should an assessment be carried out, would be after a person has been screened with something like the DAST or another screening instrument. There are many of those that are very short, that might take 5 to 8 minutes to administer. So you want to administer a screening first to make sure that somebody has a severe enough disorder to justify a further assessment, if that makes sense. Let me stop and see if there are any questions so far. So of course, as you know, the screening instrument doesn't require advanced clinical training to administer, right? You should be familiar with the terminology, what is withdrawal, what is tolerance, what are cravings, those kind of things. But I think all of you are very familiar with those terms. And so really the only things you would need to answer questions about are terms that are used in the screening instrument itself. So there's really not a lot of training. It doesn't require a psychologist, a psychiatrist, someone with advanced credentialing even to administer a screening typically for substance abuse. But for the assessment, of course, it does require advanced clinical training because you're going to need to follow up with questions about things that come up during the assessment interview, right? And so that would be another difference between the assessment and the screening, is that assessments are conducted in person all the time, whereas a screening might be administered through a paper and pencil test, right? It might be self-administered. And so clearly the screening is very short, maybe 5 to 8 minutes in length. With the assist, it might be a little longer because you ask some different questions in addition to the key screening questions that you would score. But in most cases, the screenings are very short, whereas the assessment typically would take from 1 hour to 2 hours in length by a trained clinician. So I'm going to stop there. Carrie, do you have any follow-up things that you'd like to clarify, or any of the participants? Please unmute yourself and ask if there are things that are still not clear or you'd like to learn more about.
I always have comments, but I like to make sure everybody else gets a chance.
Should I call on people?
It's always worth a shot.
Yeah, go ahead, Carrie.
Yes. So the questions, I think one of the options was at entry. Would that mean at entry before intake, before the screener, or including the screener? Because if it meant after the screener, like, then you could do an assessment after the screener before you've actually gone into either outpatient or inpatient.
Right.
I wasn't clear about that.
So, Gorika, do you mean intake into the treatment program?
Yes, like when someone comes in the first entry, I think the word was entry, at entry. So would that mean when someone has just come to the whatever agency it is and you haven't yet done an intake, or does that mean you've taken them in and like admitted them, they're part of the rehabilitation?
Right.
Then?
That's a very good question. So I will answer a question with another question to you. So does entry mean that they've already been screened for substance use disorders? How much, or in other words, how much information do you have? How much information do you have about the individual person at the time of entry?
Now that's what I wasn't clear about. Was entry a client just coming into the counseling office and you haven't even yet done the intake, or does it mean you've done the screener and now you are going to admit them to a rehabilitation?
Okay, very good.
I'll just interject that, these questions on the pre and post test are, as we know, multiple choice questions can, there can be so much ambiguity, uncertainty, cultural, language. I mean, a lot of different things. So I really appreciate you bringing that up because, I ask our instructors based on some of these questions and they might be like, I don't know what that's asking, depending on how it was written. And so,
So it's a really good question. And to clarify, I think it depends on how much information you have about the person. So Gorika, if they come into entry and you don't have any information about the person, it might be good to do a screening like the assist first, right? Before they become a participant and admitted to an intensive program for treatment, because at that point you don't know whether or not they even need treatment, right? So if you don't have any information at all, I think the idea is to provide a screening like the assist in advance before anything else happens, and you can find out some more background information about them, why they're coming in, who is motivating them to come into treatment, do they feel like they need treatment, some of those things. But I think a screening at that point is a good idea, and it might be supplemented by some other questions that you have. So I think the assessment that we're talking about would happen at a later stage if you don't have that screening information available. Now, if they come into entry, Gorika, and you already know that they've scored a very high, a 26 on the assist in one of the substances, then you have a pretty good idea that they need a full assessment, right? And you could ask a few more questions to clarify that, to make sure that, in fact, the information is correct on the assist and that they really do need some level of treatment. But at that point, then I think that's when you would want to do the more comprehensive assessment.
Okay.
Let's stop and see if you have follow-up questions, Gorika.
Okay, thank you.
Does that make sense?
Yes, that makes sense. Thank you very much.
Okay, great. Perfect. Any other questions that people have about the difference between a screening and an assessment, when you provide a screening, when you provide assessment? One thing I would say, and Carrie can also talk to this, is one of the challenges that we face, and you know this from your work, is that there are all different types of screenings and assessments available, not just the ones from course number 5 in the UTC. Those are two of the most common instruments in the world, the Addiction Severity Index for assessment and the ASSIST, which is used really for screening and brief interventions. But there are many, many instruments out there. And so it's very important to select an instrument that's based on some evidence that it gathers the right information to make decisions that you need as a clinician to place people in treatment and figure out what the right treatment services are.
Yeah, absolutely. I know in my experience, we had some of it has to do with like best practice, right? There's a way you want to do it, but then you also have challenges depending on your treatment facility. So we used to do a really, really brief screening in the courts, for example, in the criminal justice, when we had criminal justice clients. And there's only so long you're going to have to determine, the judge wants me to bring this person in, can I bring them in based on what I know? So we would do a really brief screening there, and then we'd have to do the additional steps later when we had them for longer. So yeah, it can definitely be, sometimes it's about doing the best you can with the time or what you have. But yes, to echo what Dr. Peters was saying, there's a lot of, you could probably Google and find tons of screens, but that doesn't mean that they're all evidence-based or that they've all been tested or are going to give you what you need.
What I can do is share with Carrie a monograph that we developed for the Substance Abuse and Mental Health Services Administration that was most recently published in the 3rd edition in 2019. And that monograph has a series of instruments that you can look at, and it tells you how to download the instruments from the internet. And there may be a few that actually cost money, but most of the instruments in that monograph are free of charge. And it also goes into a description of kind of which instruments are the best and how they compare against each other in some cases. So I will move on if there are no other questions. So don't be bashful. Please interrupt or jump in with questions as we go forward, because this session is all for your benefit, right? So another really good question that people had, if a client is facing moderate risk on the ASSIST screening instrument, what would be the right interventions? What kind of interventions would you have? So if somebody scored on the alcohol screen from 11 to 26, or on any of the other drugs, a score of 4 to 26, they would be in the moderate severity range, right? On items 2 through 7. So in that case, you're looking to provide a brief intervention. That would be what would be needed probably for that individual. And the reasoning, of course, is, as we talked about before, is not everybody needs a really intensive intervention. And you want to try something more moderate before you place somebody in a residential treatment program for individuals that are not at a point where they, for example, can't stop using drugs. They may be at a lesser level of drug dependency at that point. So there's a handbook. I don't know if you've seen it, but it's actually called Brief Intervention. And it's a handbook that's published by the World Health Organization. It's free of charge. You can download it and print it off. It's about 40 pages. And on page 16 of that monograph, there's a listing of the different types of brief interventions that you could consider providing for somebody with moderate risk. And again, these are brief interventions that are an alternative to placement in intensive treatment. And maybe that later on you find out that the person does need more intensive treatment. And so you move beyond the brief intervention into something a little bit longer term, right? And more significant. So just very briefly, I'll go over these, but again, and I can send Carrie the link to this to share with you, along with the link to the monograph on instruments. But there are 10 different types of brief interventions. We don't have time to go over all of them, but I'll go over them fairly quickly. One is just asking the client or the individual who comes in at entry or intake, asking them if they're interested to see their questionnaire scores from the assist, and then providing individualized feedback to them about their scores on the assist feedback report card. So one thing you're doing is allowing them to compare their own responses and level of drug use severity to other people, right? So that they might understand, oh, wow, I am an outlier. I'm using much more than a typical person would be in Uganda. And so that's helpful, so that many times people think that their use is just normal, right? If they drink 3 bottles of wine on a weekend, they might think that, well, that's just normal for people in Uganda to do that. But providing feedback about them, about their own scores, is helpful to kind of attack that myth that they're just like anybody else in terms of their drug use. And then a third area is giving advice about how to reduce the risk associated with substance use. And it might be cutting down the amount that they use. It might be not drinking and driving, things like that, to reduce the harm related to use of drugs or alcohol. Fourth point on the intervention is just to allow clients or people that you're meeting with to take responsibility for the choices that they make. So giving them some options and allowing them responsibility to make some choices about changing their substance use. Another quick thing, and none of these take very much time, really, if you think about it. Another item is asking persons how concerned they are about their scores on the assist. Once you've given them some idea about how they compare to other people, asking them, well, what's your sense? Do you think this is a problem for you now that you know that you're in the 5th percentile in terms of the highest level of drinking compared to other people in your country? And then comparing the positive and negative consequences of using and not using drugs. This can be a very powerful tool. And you can actually have people fill out a matrix of the advantages and disadvantages of using or not using alcohol or drugs, so that they can see in front of them some of typically the negative long-term consequences of use versus very few positive consequences of long-term use. And then summarizing client statements about their substance abuse and emphasizing the negative consequences that we just talked about. And processing with the individual, what's their interpretation of the negative consequences? How serious is that for you? How serious is that for family members? Have other people told you that you have a problem and that this is an issue? And then finally, this is an easy one, but giving the individuals some take-home materials, some education materials to help support the brief interventions that you just provided. And that may be a whole range of different types of materials, but that would be the set of brief interventions for moderate risk on the assist instrument. So I'm going to stop. Carrie, do you have other thoughts that you'd like to add? Or Donald?
I just thought those were really excellent. I think some of you have heard me say this in some of the walkthrough videos, but I think we do a disservice to our clients when we gather a lot of information and then we don't offer it back to them. So I really liked what you said, Roger, about, saying, hey, do you want to see what your score was? And, they may not want to, but, that's a good place. It's also an opportunity to very non-confrontationally just tell them, this is where you are on a scale. You're not saying good, bad, or indifferent. You're just saying, like you said, Roger, like maybe they think their use is normal, but really in comparison to other people, it's not, it's somewhere more extreme. So it's a good way to just give them information and education, and then like from a motivational enhancement standpoint, let them kind of percolate with that. What does that mean? Where does that, but some of you have heard my rant about we do all these tests. It's like if you went to your doctor and you did stress tests and labs and all these other things, and the next time you went in, they said, so what do you want to work on? And you're like, no, wait a minute, give me that information. So we do screenings and assessments, and then we don't always give back the information. So I'm glad that you brought that up. And I also really like that, well, how concerned are you based on what we've gone over? I think that's a really good way to start a conversation about this, the work that needs to be done. I see, Gladys, did you have a question or comment? No. Okay.
Other points of clarification, things that weren't clear, or follow-up questions that you might have?
I was trying to type my question.
You can just say it. We can hear you.
I was trying to type my question. It is to do with the addiction severity index, still with that too. On the parts of the general information, on the right-hand side, we have additional test results. I was wondering, on that part, can we put, if somebody has HIV results that we have come with, can they be put there instead of medical status? Or it's something else that needs to be put in that section?
Okay, I don't know how well you can hear her, Roger. I only heard some of it.
Okay.
No, I didn't.
Let me repeat the question.
Okay.
The addiction severity index, on the right-hand side of the general information part, there is additional test results.
Okay.
What do those ones imply? Is it that if somebody walks in with HIV test results, I can put them there? Or if they have co-occurrence disorders, can I register them there? Or I wait and put them in the medical status?
Okay, did you catch it, Roger?
I didn't hear the last part, but I heard that there was about the section for other test results. So I think, Gladys, that would be for any other kind of testing that you would have done besides the addiction severity index that you would want to note there. And it may have been for other things like motivation, or maybe another test that you do for suicide screening, history of trauma, something like that, that you would want to include as a note on the addiction severity index. Does that make sense?
Yes, it does. Thank you.
Perfect. Because, and I think that's a good question. I'll just say that, typically you wouldn't just give something like the Addiction Severity Index. You might give some other types of screens as well. For example, if you thought the person had a history of domestic violence, that they were a victim, you might want to ask some questions about that or give a formal kind of screening. So that would be the place to include those results.
Thank you very much.
Thank you, Gladys. Any other questions before we move on? And I want to make sure we have time for the case management part. So I just have a few more comments from the questions that you had before. Any other thoughts? Yeah.
I have a comment.
Yes, Ezra?
Our addiction treatment facility, one of the major ones for the government, is located within a mental health hospital. Stigma associated with the department. When clients come in or patients come in, they are not willing to listen because they already have a bias. And sometimes they don't understand the questions asked. How can that be managed? Because it affects assessment and the level at which engagement and retention can be achieved.
Yeah, very good question. So Ezra, is the issue that because of the stigma that the clients at the psychiatric hospital don't want to be placed in the substance abuse program? Because everyone knows that.
Yes.
Okay. So one simple way to address that, this isn't a perfect solution, is not to call it a drug treatment program, but to call it something else, like New Solutions, Finding Hope, some other title for the program, although people still know what that means if you're in the hospital setting. So one other thing to do is provide information about the incentives that they might see for enrolling in the program. So there might be some additional benefits. One might be that they have access to coffee or snacks. They may have a chance to live in a nicer unit at the hospital, maybe not. But talking about what the benefits to the individual are, if there's a chance to have some additional rehabilitation services that might allow them to leave the hospital earlier through the drug treatment program, that might be a benefit as well. Let me stop. Carrie, do you have some thoughts? I mean, what would make it less stigmatizing and more attractive for clients at a mental hospital who have access to drug treatment but may not want to go because of the stigma that Ezra talked about?
Those were really good suggestions that you had. That's such a tricky one. And like you said, Roger, I mean, people, even when you change the name, they know what it is, right? So, but it's still a nice, it's still a good thing to do. It's hard because I don't necessarily have any suggestions. It's more working with individuals from a motivational enhancement standpoint. That's the only thing that comes to my mind. One thing that's very interesting, and I don't know how it is in your culture, Ezra, because it ebbs and flows here, is some people don't want to be perceived as quote unquote crazy. They don't want to be perceived as having a mental health issue. And other people are okay with having a mental health issue. Well, that's kind of beyond my control. I can treat it, but don't want to be perceived as being a quote unquote addict. That has a stigma for them, or vice versa. They're willing to say, you know what, I'm an addict and I'm working on it. So it's one of those tricky things where I do think there's a lot of individualization involved, which is it's obviously not a simple answer, right? It's working individually with each client. As Roger said, the more welcoming you can make it, the more accessible you can make it. The second you make anything difficult, forget it, because they already don't want to be there. It's me with the dentist. That's the example I always use. Like, I already don't want to go. So if I go in and they're running late or the assistant is rude or whatever, I'm out of there. So anything you can do to make it nicer, better. I mean, I know in my community where I worked for many years, in the jail system, other clients would say, no, that place is cool. Don't worry about it. Everyone's nice there. They take good care of you. So, there is some benefit to try, how you treat people, right? Because the fact is the stigma is going to be there. It's
Yeah. I have two other ideas about that though, Ezra, and really good comments, Carrie. So one thing, Ezra, I think you can do is to share some information about how common the substance use disorders are among people in that setting. So I did a study in Ghana a few years ago and studies here in the United States. And we know that about from 50 to 75% of people in psychiatric hospitals have a co-occurring substance use disorder, right? So it's more common than not. And so I think you can share that information that, almost everyone that comes into this hospital has a drug or alcohol problem as well. And so this program is only offered to a select few who are invited to come to treatment, and you can take advantage of that if you like. So the other thing that I would suggest that Carrie kind of mentioned is if you could get a peer in the mental hospital who's been participating in the drug treatment program to meet with the individual, maybe when you talk to them at the intake session or afterwards, and to talk a little bit about what's involved in treatment, maybe some of the benefits. I think that goes a long ways in normalizing and making it more attractive. That they have some support, that there's additional kind of things that they can take advantage of, but having somebody that they can trust, not just a staff member, right? They might not trust us initially, but one of the peers who is maybe a senior member of one of the drug treatment programs in the mental hospital. Does that make sense?
Yeah, it does. Majorly, the problem here is the stigma associated with mental health environment. Mental health is not yet appreciated in Uganda by many, including the parents of the patients. Once that name of the hospital is mentioned, there is resistance, even before you get to the hospital.
Right. So if there was a way to almost differentiate, like Roger said, with a different name, I know, like you said, if it's there, it's hard to separate it. But, is there like a different lobby? Is there a different, not that we want to add to the stigma, but since it's there, is there a way to differentiate? I'm going there to work on, my drinking. I want to be better with my substance use as opposed to the mental health part. And I don't know if any of those things are possible.
Yeah, like you said, I find that very helpful to motivate them to be well equipped with the information that is relevant and also to educate them about mental health. Because the hospital is labeled as a hospital of mad people, insane people, not a mental health hospital, but a hospital of mad people. And they don't want to go to a hospital of mad people.
Right. Yeah, so some of that does go to a bigger issue of, advocacy on a community level of how do we change some of these names and, some of these kind of old holdouts of titles and words, and language matters in this, especially when you go to stigma.
Yes.
So that's something on a larger level ICU DDR can help with, is trying to be part of the change of how do we change some of these things at a community and country level to start to even just changing the name of a university or of a program, working with people to change the name can start to change some of that, how people perceive it. And we have people who have done it in other parts of the world who can work with you on it. I'm not an expert in that, but I can put experts together. So
thank you.
You're welcome.
Really good question. Stigma is such an important issue for all of us. And even we become stigmatized, right, as counselors and clinicians in these programs because of the nature of drug addiction. Carrie, I'm going to stop there because I want to allow time for the case management piece. There are a few other things I could talk about later if we need to.
Well, actually, if you don't mind, I think I see a question that just came through on the chat, and also, I'm not sure how great Donald's internet is, so I don't mind if we go over a few minutes into the
Oh,
second
okay.
hour.
Yeah, I see the question
You see the question?
about the effectiveness of the brief interventions across different cultures. So that's a really good question from Farida. Excellent question. So yes, the assist, as you know, developed by the World Health Organization, has now been used in many, many countries around the world. It's certainly been used in the United States quite a bit, but internationally it is the accepted gold standard, or one of the premier, most widely used screening instrument. And with that, the brief interventions have also been tested out in different countries as well. And so there actually is very good evidence about the effectiveness of the brief interventions that we had just talked about in combination with the assist instrument. Because the assist does a very good job of telling you that people need just a moderate level of interventions to start with. And once you provide those evidence-based moderate interventions, it can have a very large effect on individuals at the early stages of addiction. So I think the answer is yes. And it's a great question that we have evidence about the brief interventions in many, many different cultures and countries. I think one challenge is how you tailor that and how you adapt that to Uganda. And there may be some certain different ways of providing feedback to clients, of giving advice that you would want to flexibly kind of modify from the assist. But overall, there's very good evidence about the use of the assist and brief interventions in different cultures.
I like the question.
Did that answer your question?
Farida's mic is off. But I wanted to ask another question.
Please.
You said that severity index is mainly for adults. Is there any for adolescents that you would recommend, one that you used that works maybe just as well? You're going to send us a list, but from experience, is there any that works best for adolescents?
Yes, that's a great question. So is there another instrument that's based on the Addiction Severity Index for adolescents? And the answer is yes. 20 years ago, people recognized the need for a separate instrument because there's different issues, right? And kids are more influenced by peers, by drugs in the home, the educational system. There's a lot more issues with school, and other types of just developmental issues are quite different. And the level of substance abuse is different too, right? So the scores will be different because adolescents don't typically use as much and don't have as severe consequences as adults, right? So the scoring needs to be different. So there are several different adolescent instruments for the Addiction Severity Index. And several of those are listed in the monograph that I'll send the link to Carrie, but I can also give you the names of some of those instruments too. Carrie, I'll ask Carrie to forward those to you after the meeting today, but it's a really good question. And you're right, the Addiction Severity Index, you should use an instrument that's purposely designed for the adolescent population with that group, and not the Addiction Severity Index that's the typical one that's for adults. So
Okay.
really good question.
Thank you very much.
Other questions? I do have a couple comments about the treatment plan process, but I wanted to see if there are any other questions that you'd like us to talk about today. So there are a couple treatment questions about the treatment plan. One of the questions was about the goals in the treatment plan. And there was an indication that the goals on the treatment plan are ones that the counselor wants the client to make. And so I would just share with you, I'm sure you would agree with me, that the goals in the treatment plan should reflect not only the goals of the treatment program and the treatment counselor, but also the goals of the individual client. And so when we talk about case management that's focused on the individual and is based on skills, we talk about identifying the needs of the client and also identifying their own desires for what kind of change they'd like to see. So in other words, if you have a client that's not interested in going to the university to study and get a degree, even though you as a treatment counselor think that that might be very important, maybe that's a longer term goal, and it wouldn't be helpful to put that on the treatment plan if the client doesn't have the financial resources and isn't interested in doing that, right? So I think we're talking about the treatment plan including both goals from the counselor, but also from the client. And the best way to do that is to have a meeting with the client to decide what they want to work on, right? As well as to give them feedback from the screening and assessment results about what you see as the problems. So you want to come to some agreement with the client, ideally, before you start out on intensive treatment services, right? So that you don't get resistance. And so in some cases, we have to wait on some of the goals that we think are important, like total abstinence. The client may not be willing to stop drinking completely, and there may not be a way to enforce that, but we may want to include as a goal that they're going to very dramatically, very importantly, significantly reduce their level of drinking. So anyway, just a quick answer. Another question was, what's not included in the treatment plan? And so one thing I would share with you is that you certainly don't include everything from the assessment in the treatment plan, but only the targeted goals that you want to focus on. And by the way, those can include short-term goals, like re-engaging with the family or starting up in peer support groups, Alcoholics Anonymous, Narcotics Anonymous, if those are available, and including long-term goals as well, getting training for full-time employment, right? Establishing a different support system that aren't using drugs. So the treatment plan is really a summary of goals that you want to work on and doesn't include every bit of information from the assessment that you might have conducted. It's also a flexible document that should change over time, right? As you come across new goals, and maybe some of the short-term goals have already been met, right? So now you have some new short-term goals that used to be long-term goals.
No, I guess we're jumping back slightly, but Gladys had a question concerning stigma. I have a client who is being stigmatized by her family because of a mental health issue she is trying to overcome. As a result, her self-esteem is always fluctuating. How do I help her to overcome this, especially when she is with her family that continues to give her nicknames to refer to her mental situation?
Right. Good question, Gladys. This is a tough one. And as we know, family members can be supportive, but they can also be a problem related to recovery and rehabilitation. And in this case, having nicknames and calling them crazy or calling them an addict or having some other nickname can be very detrimental to progress. And so the first goal, if possible, is to involve the family in educational sessions about how they can help and support the recovery and why treatment is important, and also about stigma and about certain aspects of the role that the person might have played in the family in the past, and how the family can help them to move forward and take a new step. That's not always possible, but sometimes the family doesn't want to join in treatment. The best option, of course, is to have separate family groups where family members come in to share information about their own issues in supporting recovery, their own challenges, in working with somebody who has a drug or alcohol problem, and to help them become part of the treatment process by education. And we educate them about the mental disorders, we educate them about the substance use disorders, about the effectiveness of treatment, and about the unique role of the family, right? In helping or in also detracting from rehabilitation over time. If we can't involve the family, we have to provide skills for the client to deal with that and to provide some skills to address stigma and what the family members are doing. And Carrie, you have some ideas about this too, but one strategy, a clinical strategy, would be to role play. In treatment, having the client tell you what happens in the family and have somebody, one of the counselors, perhaps play the family member and actually practice how you would address that as the client, as who's in treatment, who has to deal with these stigmatizing situations. Carrie, let me turn it over to you. You have some thoughts.
Thank you. Yeah, so those are great ideas. I really like, you know, sometimes we do like the role modeling or the case, you know, doing that practice is really great. Another thing is we have to teach and model boundaries for clients because that's not something they've necessarily ever had, especially if you have families that do speak to one another that way, to be able to say, you know, to your family members, I know I've hurt you through my behavior over the years. However, you know, these comments are not okay and whatever that is. So assertive boundaries and communication. And if it's really unsafe, maladaptive, you know, are there ways for clients to have other support systems, you know, to have those support groups, to have, you know, obviously, like Roger said, the family is always going to be a really unique situation, but do they have other people maybe in the program who are doing well, who are in recovery, who are healthy, other people who are on medications or going to group or whatever it is? Not to replace, because you can't, but to make sure that they do have positive support systems. And remember, going back to the boundaries, that we teach them that not just through showing it, but through how our boundaries are with people. So being able to have, you know, model those behaviors of what is appropriate and what's not. And sometimes, you know, people, because they've grown up with families without boundaries, don't even know that that's an option to say to someone, you know, and just because you set a boundary doesn't mean people are going to follow it, but to teach people at least how to have the boundary like that.
That's great. And the only other thing I would add is that there are some independent kinds of interventions for self-esteem that you could work on with the client. And that, again, is based on oftentimes their own strengths. And Carrie has some great examples of this where she'll share with the client about kind of reframing that they've come through a lot, even though they've been in a bad situation with drug abuse, that they've actually been very resilient and have come through some of these crises in their own life and have been strong enough to deal with these things, even though they're in treatment right now and still have some problems. So very important to independently work on the self-esteem as well as the specific stigmatizing issues within the family.
If I may add quickly, the families I've worked with before in Uganda, I've realized that people battling addiction are hurt by people who love them. And it's not intended. So I found it very important to let the client know that the reason they are hurting with the words they say, one is frustrated love, two is lack of either information or knowledge. So when I start with the client to appreciate that they are frustrated and the statements they make is not because they hate him or her, but because they are frustrated. They don't understand what addiction is most of the time, and they have been hurt for so long. So when he appreciates, like you said, we help him or her to see the impact of the disease on him as a person and the people around them. Then he also appreciates and is motivated to improve on his relationship with the family. And when you get to educate the family as well, and you tackle both at maybe at one time at a time, one whatever, alternatively, eventually, by the time you bring them together, they will have understood how to relate. And I've come to realize that the best recovery house is a home, it's a family, not a treatment center. So the client needs to understand that the biggest part of recovery will take place with the family. And usually the clients are ready to abandon their family and quit because of the stigma and abuse that has been going on. But if they don't realize that recovery will happen most of the time in the family and they need it most, they will not appreciate it.
Ezra, that's a really important point. I think we all have experiences, though, in which the family can be very detrimental, corrosive, and not supportive of recovery. And they may actually be using alcohol and drugs in the home and have their own problems with anger or creating stress for the client. And so I think you're right. I think the ideal is to have the family become a major support system and help in the treatment process and help in the recovery process. But in some cases, we have to try to bring in the family to educate them, like you said, about their own frustrations in the past and about their own stigmatizing behavior that doesn't help the client at all. And in some cases, we have to understand that the client needs to go to another environment. That, as Carrie mentioned, they need a new recovery support system altogether. And it may be not just the family, but the friends that they spend time with. And that can be a long-term process, and it's not always practical, right? If there are no other solutions and the person doesn't have money to live in an apartment of their own and that kind of thing. So very important points. Thank you.
Thank you very much for your contributions. Like Carrie said, boundaries. This is a student, a school age going student, a school age going girl who is battling with depression. So her family does not understand anything to do with depression, and they are not willing to come on board to help them understand. When she's at school, she's fine. When she goes back home, things become worse. There is no food. They don't give her anything like food. She'll have the little food on the plate compared to others, just because of what she's going through. So we have done boundaries, we've done rephrasing of her statements. You know, when you say this, I feel hurt when you mention this, I feel hurt when you call me this, but none of them wants to hear. But every time she's away from home, she's fine. She's always okay. Thank you very much for whatever you've told me to do. I will try and I will see how we progress. Thank you to everyone.
Thank you. One question I guess I would have is how did she end up with you? Like, what was her referral source, or like, did the family bring her to treatment?
She studies where I work.
She studies where you work?
She studies where I work, so she brought herself. And her family is far away from where she goes to school. So they can
I see.
to the school.
Okay. Because that
wanted-
sounds, oh, go ahead.
I also wanted to add that Rogers talked about alternative support, recovery support systems. We came up with an idea of recovery houses in Uganda, but they are not yet set up. We have a challenge of cost. Alternatives come at a cost. Treatment services are at a cost, and the majority can't afford. The only alternative we have is the relatives, people around you. And in Africa, specifically in Uganda, what I know is that when you talk about self-esteem, a family is very critical. when you don't have a family attachment, it also affects your self-esteem, whether you are battling addiction or not. So culturally, the environment, because of cost and culture issues, we find a challenge on how to handle addiction treatment. Like we said last time, some of it is interpreted as witchcraft. It's interpreted as witchcraft. Even people that have gone to school will tell you, no, this is not a mental health issue. It's a behavioral problem. Fix yourself. So we are that far. We appreciate all the knowledge you are giving us. We are picking everything. We have to come back on our drawing board and look at our culture, look at the resource capital that we have, both the state, community, and on the individual level, and the skills and abilities that we have as professionals. After this training, we shall have to network and keep together. Keep getting back to you and looking at our environment and then getting back to you so that we improve with your support. Thank you very much.
Yeah, thank you so much for your comments. And I think, Ezra, you point to the problem in many countries, not just Uganda, of the long-lasting effects of stigma and how difficult it is to change. And it's really a community values, community perceptions, things that have been passed on from generation to generation, right? About what it is what is drug addiction and what is behind it. And so many people don't believe that it's just a biological issue or one that's based on a set of problems that have developed over time, but that it is due to demons or witchcraft or some other moral weakness of the person. And so there's a lot of education yet to be done, right, in the community to change those perceptions. And that is a long-term process. We're talking 5 years, 10 years for the community to change. So, Carrie, I don't know about your thoughts, but I believe that because of that, we have to address stigma with the clients in our treatment programs and provide some strategies for them to be able to deal with stigma that they not only feel about themselves, but that other people, like their family members, Ezra, that you talk about, that they are stigmatizing the client as well. And so I think the only thing we can do in some cases is to provide some skills for the clients to address stigma. And part of that's the way they think about themselves, right? Their thought processes and belief system.
Yeah, and that's why I said earlier, I hated, I almost hated to say it, but that's why I said it's like we have to do a case by case, One of our colleagues, Roger, and my colleague, Kristen Kasilik, does a ton on stigma, and she's I can send you some of her resources. She's more in the mental health field, but self-stigma being one of the really big things that would probably be appropriate for you guys to work on in your area of, it is really around the world, but from what you're telling us, sounds like a big problem of, it's everywhere out there. So you're stigmatizing yourself as well. So we can certainly give you some resources on that as well. All right, well, I see a question, but it's case management related, so I don't know if we want to, if we have any more comments or questions on this. And Donald, are you able to chime in with us on if we move to case management now?
Thank you. Not now, just been listening. Nice stories from Uganda. And probably, Kerry, I'll be coming back to you to see if we can extend this to other countries in the East African side. Uganda has made great progress.
Yeah.
Yeah.
Okay, so Donald, are you able to comment on some of the things I sent you via email? Do you have that?
Not at the moment, Kerry.
Okay.
Yeah.
All right, well, I'm going to start by answering this question then, and anybody can chime in. The question is, doesn't inter-program case management pose a threat of losing clients and redundancy in private practice?
Not if you have done it well. If you have followed the regulations and build a good relationship with the patient, most likely the patient will hang in there with you. And we don't work to lose patients.
Yeah, so I think it's a really great question. And yeah, of course, that's like Dawn said, you really have to do it the right way. Because it is possible, you know, for if you don't have the services available at your site, we really have to do what we call a warm handoff, which means that you're not just saying, hey, you know, Betty, go over to you know, Josephine's program and see you later. It's that you are able to say, hey, there's this great program. I know the person there, or here are the criteria. Here's where you go. And we check back and we make sure, did you go? What happened when you went? Oh, they don't take people with this anymore, you know, and then you're updating your own referrals and your own information. And as far as that's as far as the losing people goes. And then as far as redundancy, certainly if we have services available at our site or within our agency, we shouldn't be referring anyone out.
If I can, there must be a family to end of my relationship with the patient, to plan for the patient after discharge, so that my investment is not lost.
Mm-hmm. Yep. Thank you. And so are there other questions on case management before I dive into a few things that I saw? What you learned in course 6, what model of case management would you say that your agency or organization uses? Anyone? Did you assess based on what we talked about in course 6 what they're using either where you work or where you have worked? I can tell you that in the agency that I was running for many years, we were using the more rehabilitative approach where the clinician was also providing the case management. So the clinical or rehabilitation model. And there are definitely pros and cons to that, as you can imagine. For one being just the counselor and client, you know, case management overload on the requirements of them. However, where I was primarily focused was a residential program. So a lot of the needs, like, you know, obviously housing and food and things of that nature were already provided within the agency. So that made it easier. But like when you had a client getting ready to leave or when they had outside needs, it was a lot on the counselor. However, to Farideh's question, you didn't lose clients, you didn't have redundancy because the counselor who was serving as the case manager was providing all of the services and knew holistically what was going on with the client in every area. Other experiences with case management? Other questions or comments like Farideh asking about the issues with inter-program? didn't see a lot of things that came up in the post-test, so that's why I wanted to see what questions you had personally. Did all of the different models make sense? Farida, I think you might have been your internet might have been poor for a minute, so you missed some of our discussion of the inter-program case management. Is that something that you have experience with?
Oh,
Yes, we can hear you.
okay. I have no experience with that. Actually, I came across it for the first time when I read.
Okay.
I'm in a situation like most of the places that handle people with SUD here in Uganda. They are private, you know. There are few that maybe also not even non-government organizations. Numbers really matter. They need to show the work they are doing. They need to show that they have these clients and they're helping them. So I'm imagining you have maybe 3 or 2 other entities that you're referring the clients. How do you keep track?
How do you keep
Won't I
track?
get lost in one? How do you keep track? And won't you be losing clients?
Right. So what Donald and I were suggesting is that if you have a relationship and an investment with your client, then you won't lose them because you'll be, one of the things is you're only referring them out if it's a service you can't provide. So like in the agency that I was working at, we provided quite a bit of the services that they needed. But if there was something that we couldn't provide, we worked with another agency hand in hand and got that client to go there for that service. We documented it in our chart and we still kept the relationship with the client. So I wouldn't send a client somewhere else for substance use disorders, but I might send them someplace else for mental health if we provided insight, or I might send them someplace else for medical or something that we didn't provide on, we weren't able to provide within our agency. Does that make sense?
It does.
Yeah. And I mean, honestly, we really try to be a one-stop shop, but you brought up a good point of like smaller, private, where maybe that's all they do is counseling for SUDs.
Hello.
Yes. Betty?
Yes, please. Thank you. I just wanted to add on to what Farida has just said. The service is necessary for case management, external resources, for effective case management. I realize that really we as a country are lagging behind. And as I was reading through this course, I was just thinking of us as this training cohort, the need for us to brainstorm on what is possible for us. Ezra said we have a national mental health hospital, but it does not even meet the need of clients within Kampala. And we have so many patients who do not even know where this hospital is located in Uganda. They have never been there and they will never be able to reach Butabika. And certainly there are no structures at grassroots. And so talking about inter-program, I really thought this gives us an idea of what is ideal, but I think as a cohort, maybe after this class, moving forward, we really need to brainstorm on what is it that is possible for us, what can we do that can help people who are struggling with addictions. Otherwise, I saw most of course 6 as something ideal. I tried to bring it in context, but I just felt overwhelmed. I couldn't see it applying in most parts of Uganda. Thank you.
Thank you so much. I really appreciate that honesty and vulnerability in the discussion. I love the idea of the cohort working together on some of these things, and obviously any support that ICU DDR can provide to try to help move the conversation along. As I said earlier, we have a lot of people who've been in these kind of situations in other parts of the world and are either a little bit farther along or maybe they're 10 years down the line. And just for the record, I agree with you, Betty. A lot of this is ideal. That doesn't mean that every place has it, and it definitely doesn't mean that, I wouldn't want you to leave feeling like, oh, we're so far behind. That may or may not be the case. I'm sure, I know there are challenges everywhere. And I often talk about what's in the book and what we want to aim for, but then what you have to do in practice, right? Which I think is part of what you're talking about. But yes, please continue the conversation, regardless of whether we're doing this course. Work together to see what you can work on, what support you need, what resources you need. Do we need to have additional trainings from people who can help? Are there ways that you can advocate at a governmental level, or what are the ways to get finances to do some of these things? There's a lot of steps, and hopefully getting some university support will help for all of that. But yeah, do keep in mind as far as I would never want anyone to feel discouraged. A lot of what's in the book is the ideal. It doesn't mean that, oh, everywhere in the world is doing this except for us, because that's definitely not the case.
Hello?
Yes.
Let me take this opportunity to 15 years down, some improvement. We have new rehabilitation that have been set up. We have now just that tries to have a single point of they are overwhelmed by numbers because they don't have enough space. They don't work private institutions. But surprisingly, all centers get experts from the same hospital. So if we could also put more effort we could there as we go. We also encourage the private institutions. I have been there a number of times. Of course, the space is not enough. The demand for the services is so high. We cannot meet the needs for the people that need treatment. It has just been expanded, but still you have to book to get. But at least are in place. But being a government hospital, there is a way it works. They are slower. We can collaborate with them to improve. But if there is any support that we shall get, we shall work both with the government hospital and private institutions that are credible and improve that we have. But we are progressing by the fact that we are even here now.
There you go.
I thank my colleagues for putting in time. They are very busy people, but they always find time to do this, which shows that they are crying for change. They want to see a difference in this country. They want to make a difference. That's the sound that you are hearing from us, that people want to see something done differently. They want improvement. They
And
want
that
something
commitment is
positive.
amazing. That
So
commitment
thank
is
you, my colleagues.
Yes, thank you, thank you, thank you. Round of applause. Yes, no, and we're so grateful to be part of it in any way. So as I say, you know, we continue, like you mentioned, capacity building, you know, there's all these different things that we're here to help however we can. So a couple things I see. I see a question for Roger when he's available. And then I see in the organization where I work, we are already working on the referral database. With the knowledge I've acquired in case management, we shall be able to handle better. So thank you. That's a good comment. I mean, it's twofold, right? So you want to have a strong referral database, but if there aren't places in the area, in the region to send people to, that you can't create resources that don't exist. So, like I said, don't be discouraged. Just make, to the extent that you can, make relationships, make yourself aware of different resources in your area, then do that. And, you know, you can't create things that aren't there. So, if you're seeing an opportunity, then maybe that's a discussion to have with local leaders or in the university of, you know, we have a lot of clients who need to be referred to XYZ and we don't have that. How do we build that in the community? Roger, are you there? I don't know if Roger has.
I'm here. Sorry, it took a while to unmute. Yes.
No problem, no problem. So there's a question that hopefully you can help with. What knowledge gaps exist in assessment and interventions in SUDs, especially in Africa? And Donald
Wow,
might be.
that's a great question. Do we have a couple hours? We could, no. I don't know all the details about what the gaps are in Uganda and other parts of Africa, although I've worked with several different countries. I think around the world, just one thing is to identify what are the options for different instruments that might be used. And so I think one gap is that people believe that maybe they can create their own instruments and that they're just as good as other type of instruments out there that have been developed based on research. And my response is that not all of the assessment and screening instruments are created equally, that some are more valid and more effective than others. So one thing is, you know, everywhere, even in the United States and other countries that have been, you know, developing treatment programs for years and years, there's still major gaps in what type of instruments we use and how we actually use the information based on that. And so when I travel and visit programs, oftentimes I will look at their assessment instruments and find that they've just been using an instrument that was developed years ago and that they haven't added much to it to include key areas of information, such as trauma, history of violence that people may have experienced as victims who are clients in the programs, other areas like that we need to identify. Another area that's really important is criminal risk. And that's an area that's now beginning to get a lot of attention as we begin to target certain populations for treatment that may create the best economic return on our investment, because we have scarce resources in Uganda and every other country to provide intensive treatment. And so we don't want to provide treatment for people who are just casual drug users, right? Casual users of alcohol, or people that may not benefit as much from our intensive treatment programs. And so another area of assessment and screening is to look at the target population, not only that they need to have severe substance use problems, but also that they need to pose a risk of, in many cases, it's important to look at the risk for involvement in the criminal justice system. Because if we can have an impact on that population, we can save a lot of money and keep people out of Ugandan prisons, for example, right? And if we can do that and place them in the community instead in treatment programs, we're going to save a lot of money. And so that's an area I think around the world and in Africa as well, that's a gap. Let me stop there. Carrie, do you have any thoughts, other things to add?
I don't accept to see if Donald wanted to add anything to that, or Ezra.
Well, in Uganda, we are here, yes. You talk about assist. In some countries, you say assist. Maybe out of 10 professionals, 9 will know what you are talking about. No, even less. So we need to do more of training in assessment and treatment, and then the interventions themselves, and then do more research and try to make these things relevant to us. But we need to train, hands-on training. We need hands-on training of people that are willing, are motivated like us. We need more skills development and skills impartation.
That's a really good point. Yeah, I would just add one other thing too. I noticed that the comment asked about interventions in substance use disorders. And so I think I noticed a gap when I visit programs around the world and here in the United States that they don't always use evidence-based manuals that can help guide treatment and provide a more consistent approach to treatment. What I see more often is counselors just doing whatever they want to. And there may be some principles that the entire treatment program agrees to, but the counselors are left to their own ideas about what they want to do in treatment instead of using manuals to help in that process. And so partly it's an issue of cost because many of the manuals cost some money. Sometimes it's a matter of interpretation. For example, in Spanish, we don't always have interpretations of manuals that are evidence-based in Spanish. In Africa, there are certain countries that speak French, and so that would be an issue. But I think just having access to evidence-based treatment manuals is an important gap, and knowledge of maybe some of the new technologies as well. So Donald, thank you for your comments about the need to have hands-on training. I think Carrie and I have worked on a UTC series that's called the Mentorship Curriculum for UTC Basic Level 1 through 8 of the different courses, and it provides more of a hands-on skills-based approach for counselors to learn how to practice some of the skills in evidence-based treatment of substance use disorders. And so I would encourage you to think about that as well. There will be some additional trainings that we have in that area. We have a set of global trainers now for the mentorship courses. Let me stop there.
Thank you. And I see Ezra has posted international standards for the treatment of drug use disorders. So thank you.
This is a
Donald?
manual. This is a manual that can be downloaded. It's a UN manual. I think it's as current as 2019. It could be of help about the interventions.
Donald, did you want to add anything?
I'm okay, Kerry, thanks.
Okay, thank you. So it sounds like, and maybe I'm wrong, but it sounds like maybe some of this case management manual didn't feel as relevant to what you're doing in your region. Is that fair to say?
I would say no.
Oh, it's not relevant, or no, it's not fair to say?
No, I'm saying they are relevant. It's not true that they are not relevant.
maybe relevant's not the right word, but I mean, like, when you see that, when you're reading that, when you're learning that class, does that feel like, well, that's not what we have here?
Well, we may not have what we see, but it alerts us that we need that we see. But there are some things that we are already doing, like we do direct counseling, yes. We do referrals, yes. Now, like the National Hospital that has all these departments of mental health, they have a single point of contact. They refer clients to all these departments internally. They don't release any client. They are not restricted by resources, and the incoming numbers are so high. But the knowledge is very relevant, and it challenges us to look into improving on what we are already doing. So this management is important for us.
Okay. Betty, did you want to add something?
Yes, I wanted just to agree with what Ezra has just said. The information is all relevant. The fact that we don't have some of what we see in the courses doesn't make the information relevant. If anything, it's such an eye-opener. We see what is really.
Did we lose Betty, or did you guys lose me?
We lost Betty.
I think we lost her.
I thought maybe I was gone.
Maybe let me add something on what you were saying. Just like Ezra, I think it's something for us to aspire to. Maybe among us, there are people who would like to set up actual agencies to do this work. So we are getting this information at a time when we can plan and say this needs to be included. So we will include it when we set up our own agencies. The places where we work now, we can pick a bit of this and a bit of that and maybe include it in the setup that already exists. But yes, I think it's very relevant.
Okay. One thing I will tell you that can be really strong with case management, and again, I don't know what resources are available, but when I was working at a treatment center, I was being tasked with having a lot of things on site so the clients didn't have to leave, and it was a very overwhelming task. And what helped us was partnerships. So we would find, well, we have a room, we have a space, and we would find like a local medical facility or local medical providers and say, well, we have a space and we have clients available to you if you can provide the medical care. So, and they were able to bill, and, so just if there are people out there who can provide the service, finding some kind of partnership or something that's a win-win. We had to provide a certain number of clients so that the medical folks could bill as they needed to. But we were able to provide a space and sort of a captured population of clients, for example. So there are ways to, get over things that maybe at first seem kind of insurmountable or seem like, how do we make this work? And I see a comment, the information is relevant. However, we need more professionals accessing this information. This would perhaps increase the impact. Yeah, so what I will say to that is what we always try to look at, and Brian Morales at the INL through the State Department, we always talk about sustainability. So we're going to put some responsibility on you all that once you've been trained, can you start to train other people on some of this so that we can make that footprint a lot bigger? That's why we're in training. Yep. So we have a few minutes left. Any other questions or comments before I dive into some sort of housekeeping? Okay, so our next session is currently scheduled for February 16th. And I just want to make sure that that's on everyone's calendar and make sure that it works. And that will be the wrapping up or the final enrichment training that we'll have. So does anyone have questions or comments on that? Are we still good for February 16th? Maybe thumbs up or... All right, cool. Excellent. So please keep in touch through the WhatsApp or on Healthy Knowledge and let me know if there are things that you need, things that you're missing. Thank you for those who have let me know if there's been issues accessing videos and we've all worked together and found what we needed. My thanks to Donald and to Dr. Roger Peters and to all of you. I know how busy you are, and I appreciate that you're watching hours and hours of videos and you're taking the time to do the post tests, and I hope you'll also do the evaluations that are posted on the Healthy Knowledge site. And thank you for being here. And I know that it's, as Ezra said, how busy you are, and we're well aware of that, but we appreciate your time, and we're glad to be able to provide this for you. Did you want to say anything, Roger?
Can I ask you a question, Karen?
Please, yeah.
How is the last going to look like? How are we getting, what is going to happen that day?
So it will be similar in that we have course 7 and 8 to complete, but then we will also have some kind of wrap up final graduation sort of proceedings as well. All right, Donald or Roger, did you want to say anything before we part?
Oh, just thank you. And I enjoyed working with each of you. Good luck. And again, congratulations on your work with the UTC. And I know each of you are leaders in the field in your own region and country. So keep up the good work and let us know if there's anything else that we can do to help. Thanks so much.
Thank you, Roger. Donald? Donald is at a hotel, so I don't know how well his... Yes, we can hear you.
Hello? Yeah.
We can hear you, Donald.
I'm just grateful the session. It was very lively. Yeah, the session was quite lively and nice and relevant. I like the participation of the Ugandans. I think I'll be looking forward to the next one next February. I mean this month. Thanks.
All right.
To Professor
Thank
Peter again.
Thank you.
Yeah. Otherwise, I'm grateful.
All right, we're glad you're here. Thanks to everyone. Have a great rest of your evening and day, and take care.
Thank you.
Thank you.